Managing severe bleeding after birth. A woman with postpartum hemorrhage can go into shock rapidly. This video will show how to work as a team to save the life of a woman who is bleeding and going into shock after birth. If a woman is bleeding heavily or continuously, shout for help. Ask for your postpartum hemorrhage emergency kit, which is fully stocked and easily available at all times. It contains medications and syringes, IV supplies, urinary catheter supplies, sterile gloves, a uterine balloon tamponade kit, blood drawing supplies, and a suturing kit. Rapidly assess the woman. With your team, start first care steps right away at the same time. Act fast. Your priority is to stop the bleeding and manage shock. Let the woman know what you are doing and why. She will need many treatments quickly. Let's focus on each of these priorities. Find the source of the bleeding and stop it quickly. There are 3 main causes. The first and most common reason for postpartum hemorrhage is a soft uterus. Massage the uterus or squeeze it to make it contract and stop bleeding. Also, insert a urinary catheter to empty her bladder. This will help her uterus contract. Continue to massage the uterus until it stays hard. Next, check that the placenta is out and complete. If a piece is missing, it needs to be removed from inside the uterus. And last, check for bleeding tears. If a tear is actively bleeding, press a cloth firmly on the bleeding area. Then suture it. If you determine the cause of bleeding is a soft uterus and initial measures of massaging the uterus and emptying the bladder did not stop the bleeding, there are 4 more approaches. First, give medications to contract the uterus. First, give oxytocin 10 units IM as emergency treatment, even if you've already given this injection immediately after the birth. Then, draw up 20 units of oxytocin and add it to 1 liter of normal saline or Ringer's lactate. Run it as fast as possible. If the bleeding doesn't stop after giving oxytocin, give the woman misoprostol, 4 tablets under her tongue, or methogyne, 0.2 milligrams IM or IV slowly. But avoid this with high blood pressure, preeclampsia or eclampsia, a retained placenta, or heart disease. If you don't have these medications, repeat oxytocin 10 units IM 20 minutes after your last dose. If these medications fail to stop the bleeding and you have TXA, give 1 gram IV over 10 minutes within 3 hours of birth. If the woman is still bleeding heavily, next, try bimanual compression. Gently insert your flattened hand into the vagina, but not inside the uterus. Place your other hand on the woman's belly. Make a fist. Fold the uterus forward and squeeze it between your hands until bleeding is controlled and the uterus contracts. Compressing the aorta can also stop the bleeding. The point of compression is at the umbilicus. With a closed fist, press straight down over the umbilicus to compress the aorta as you feel the femoral pulse. Press down until you no longer feel the pulse. This will stop the bleeding in the uterus and the vagina. And finally, if the uterus remains soft, prepare a uterine balloon tamponade as your team member continues to compress the aorta or massage the uterus. Place the device in the woman's uterus and fill it with fluid until her bleeding stops. While you are stopping the bleeding, keep evaluating the woman's condition. Is she going into shock? Check her pulse and blood pressure every 5 minutes. Remember, an increase in the heart rate is the most sensitive indicator of shock. Learn to do a quick pulse. Find the pulse on the wrist. Then count it for 6 seconds. Add a 0 to that number. This woman's pulse is 110. A rising pulse, 110 or more, and a dropping blood pressure, less than 90 systolic, or signs of shock. Look to see if the woman has other signs of shock. Fast breathing, cool, sweaty skin, acting anxious or confused, or feeling thirsty or dizzy. Treat the woman for shock even if she has only one of these signs. Position her head flat so that blood can go to her brain. Start oxygen at 6 to 8 liters per minute. Give fluids rapidly through 2 IVs using large 16 or 18 gauge needles. Infuse normal saline or Ringer's lactate wide open. The woman will need 3 times as much IV fluids as she has lost in blood. For every liter of blood, she will need 3 liters of IV fluids. Collect blood for hemoglobin, blood type, and a bedside clotting test. If a woman is severely anemic with a hemoglobin below 7, she needs a blood transfusion. Put an anti-shock garment on the mother if you have one. If the woman is bleeding continuously or heavily, if she has pieces of placenta still inside her uterus, or if she has abnormal laboratory results, she needs advanced care. If your facility cannot supply blood transfusion and surgery, the woman must be transferred. Transport her without hesitation if you cannot effectively help her. Act fast. Make contact with the hospital to let them know to expect the woman and baby. Write a referral note. Include all actions you have taken to treat her hemorrhage, including medications, times given, and doses. Transfer the woman with a balloon tamponade or the anti-shock garment in place. Maintain the IV drip and continue to monitor the woman. Keep the woman and baby together and warm during transport. Remember, when a woman is bleeding after birth, do all you can with your team right away. Stop the bleeding and treat for signs of shock. transport her without hesitation if you cannot effectively help her.